All right, so I am, again, Catherine Mushik. I'm from Greenville, South Carolina. We're in the upstate, and we're Prisma Health, which is a made-up name, but Dr. Anderson and I are the providers for a now all-age comprehensive sickle cell program. And so I am presenting one of our adult patients with kind of a recent trend we've been seeing with fentanyl use. And so this came up a little bit with a younger patient, but we just have a lot of it happening. So we're just kind of wanted to get some information. So this guy is a 43-year-old male with SS disease. His actually last admission was 210, and he has now been to the outpatient clinic twice in a row for appointments. We have not seen him, and I'll go into that a little bit later. But prior to that, he did have 2 in January, and then in 2022, he had 20 admissions, which is one of the reasons why we haven't seen him outpatient. He is, the biggest issue is pain. All of his admissions were for pain. He presented to the hospital with leg and back pain. Typically, he does not have any AVN, mostly just on x-rays. He hasn't followed up with MRIs, but has not seen any major bone deterioration so far on those. He is seen here by Dr. Alan Anderson. He started seeing him in 2020. Well, kind of like 2019 really was when he was following up last. So he came to us from our adult oncology colleagues at about that time. And that was, Dr. Anderson started the program in 2018. So we started getting patients from them in about 2019. He came to us on 30 milligrams morphine B. Oh, no, sorry, he wasn't on that at the time. He's right now on 30 milligrams of morphine BID. And then he's on 20 milligrams of oxycodone, 90 tabs monthly, and he has been on that since he came to us. Since he started with us, he was on like 500 of hydroxyurea, I think, when we started. He's on Neurontin 600 milligrams TID. We've had him up to as much as 2,500 of hydroxyurea. He does respond great when he takes it, and he does have, with hospitalizations, some issues with lower hemoglobins and stuff. So he has been kind of anywhere from 1,000 to 2,500 over the past couple of years. He is on lisinopril 20 milligrams. And then typically inpatient, he goes in, gets, his PCA started. He doesn't typically come to our hospital. So he goes to a lot of the smaller hospitals that are kind of around our community that are Prisma usually, but not that we are notified or that know that he's going in. And you can scroll down a little more. So his history, really amazingly, when he came to us, we were most concerned that he was a pretty heavy smoker, was having some oxygenation problems, likely from some sleep apnea. We started trying to send him to ENT. He did go to ENT one time and work on pulmonary things. He did not follow up with pulm. Initially, was just working on some smoking sensation, and then also, just narcotics in general, because he was on a large amount of oxycodone when he came to us. He had an echo when he first started seeing us in 2018, late 2018, and that so far was pretty good. He didn't have a whole lot of hypertension or anything else going on at that time. And then most recently, he's, of course, having a lot of admissions, a lot of pain. And then we saw him in the first time kind of outpatient, and we did a urine and he had fentanyl in it. So we've been worried about his depression even in 2019 when when he started seeing us and we started to kind of worry about him. He stopped early 2020 with follow-up, and then had actually lost insurance at that time. So we had one appointment where he met with our social worker. We were trying to get him back with insurance, but he had lost his disability, lost insurance, kind of lost everything. He was still living with his wife at the time, but he was experiencing depression. And then since then, we are worried about his fentanyl. So he did have some fentanyl positives in the hospital. Unfortunately, it was never addressed. And then sometimes they did 5, sometimes they didn't even look for fentanyl. So when we did the 10 confirmation on his kind of first outpatient follow-up is when we saw the fentanyl. So Dr. Anderson did reach out to him to talk to him about that. And, I think our plan is for him to follow up this week actually and discuss options going forward. The interesting piece about this is his social history is kind of when everything fell apart. So when he lost insurance and stopped following up with us, but also stopped, following up in general. And then there was some issues, I think, going on with marriage and wife at that time. So he started, 2020, late 2020, had one more kind of outpatient follow-up with us, but then started in 2021 just going to the ED a lot and then being admitted for pain. Again, we went over the hydroxyurea, and then these are kind of some recent, obviously blood pressure is, out of control. He has had some compliance issues probably with lisinopril, but labs looked pretty good. He has had some increased creatinine in the hospital, but again, not really a whole lot of things were addressed hospital wise. He usually runs about 9. He has a good response to hydroxyurea, can get up as high as 10 when he stays out of the hospital, which now has been consistent for about 2 months. And so I think the biggest thing is this recent positive fentanyl. And he was negative for oxycodone, which is what he's prescribed. And the wife was out of the picture from about 2020 till just 2 months ago. Kind of other interesting facts, when he first started seeing us, he said he had 3 kids. They all had trait. His 8-year-old showed up in our emergency room and actually has sickle cell disease. The mom and did not admit that she was married, but they have, they had the similar last names. We kind of knew that they were probably together. She showed up in our ED about a year ago, and mom said she had no idea she had sickle cell disease. And so was supposed to follow up in our clinic and didn't. Now they have both come together as a family. So he's back with his wife and the daughter, and she's come for her sickle cell appointments now 2 months in a row also, and is starting on hydroxyurea. He has only been on hydroxyurea for about 5 or 6 years in total. So I think previously was followed in Colombia. And then, like I said, was in one of our adult oncology groups prior to starting to see us. He actually doesn't get transfusions. It's not really a religious thing necessarily. He says they don't make him feel good. And he admits that it makes him feel funny, but there's no DHTR ever documented. I don't see him ever having an actual issue with transfusions, but he does say that he really refuses them even when his hemoglobin drops in the hospital. But so we're not quite sure if he has that history, but he says it wasn't a DHTR, but he does say he doesn't like to get them. And the other interesting thing is, back in 2020, when he lost his insurance, we had been trying to get him in because he was having some blurred vision. And he did follow up finally and had some retinopathy, of course. And I remember I was talking for a good week with the retina doctor, the specialist, and he was supposed to go in for evaluation and some, treatment. And he was really concerned about him, but he was in the hospital at the time. So I kind of went through the whole weekend, let's get him out on Monday, talk to him, talk to the doctors. And he refused basically to go home. He refused to be discharged. He had been in the hospital at 9 days at that point with pain. No really other issues. His hemoglobin was stable, did not have acute chest or anything, but just absolutely refused. When I talked to him about it last time, he said he was worried that he was going to go blind. And in early 2021, he is now blind. So that has, of course, also offered a lot of difficulty. Originally, when he was not with his wife, he did not have any transportation. He was living with a family friend. And he had home health nursing and all these other things that they were trying to set up through the hospital, but was still not able to get to appointments. We've called him multiple times. He made appointments, and then he would just end up kind of back in the hospital. And this was all kind of 2021, 2022. And so I guess our biggest concern is, the good news is he's back in with us. He's now come 2 months in a row. Is very, seems like he wants to make some changes. Dr. Anderson, again, did reach out to him about his fentanyl. And I know a lot of people, adult providers have a lot of experience with Suboxone. But ours in the past has kind of been send them to some outpatient area, but there's really nowhere to do that around here. So I just kind of, I think, wanted to see if you guys had standards and what everyone does kind of across the board. And I know this is there's so many things wrong here, but I think, we could talk about this and all of the, the problems that started with insurance. And this just goes to show you, especially in the Southeast, how hard this can be. But I think the main thing is just some guidance on where you would go here.
Thank you, Katie. That is really a hard case. And I know many of us have seen similar cases, especially in the adult world. And in fact, what we learned, I can't remember exactly when, I think it was 2020, that fentanyl was added to our drug panel, which it hadn't actually been there before. And so we found that a few individuals who were prescribed oxycodone were actually supplementing their oxycodone with street drug, which was cut with fentanyl. And so we often found that that was the case. A couple of thoughts, I guess, and I'm sure many will have them. We use a lot of Suboxone. We've had some really great successes, but you can't do Suboxone unless you control the sickle cell disease and really understand whether this is addiction versus dependence versus pain. Now, if Dr. Pat Carroll, the best psychiatrist ever, were here, he would tell you it doesn't matter which of those things it is. He would tell you that what you still have to fix the issue. And I say that because I think that that if it's more on the addiction front, that some of the addiction services, such as the intensive outpatient treatments, are much, much, much more beneficial than just treating everything else and getting the psych help. But some things I think that are really important is making sure that you have an individualized care plan that every hospital can see if you're all connected. If behavior is usually the driver, so no matter what the problem is, it's behavior driven. And once you control the sickle cell, this is somebody who really shouldn't be getting a lot of IV opioids because that's probably going to further whatever this dependency is. So making sure you have that pain plan there is really important.
Yeah, and he does have one now. I mean, we did it 2 months ago, but because that's the first time he's been outpatient. But he does have a good one in place. And our ED follows it and will reach out to us. The problem is a lot of these smaller hospitals around us that he is.
If you could call him, if he goes there, I'd absolutely pick up the phone and call them. More often than not, when I've had this experience, they're actually really grateful to talk to me. Oh, we didn't know. This is great. We'd love to have that pain plan. We'd love to alert you. They realize that there could be a problem as well. And so I often find that we're scared to call people sometimes, but that many of the outside providers find it helpful. The only other thing I was going to add before I stop talking is that we have some people who have told us that same thing about transfusions. Specifically for 24 hours afterwards, they may not feel well. And I always explain this to patients that we're giving you a bunch of deoxygenated blood in that bag. And so until it goes all the way through your body, you may not feel well, but that if you give it 24 hours, you can really adjust and improve. So that's just something else to think about. I've also found they do better on pheresis than simples. and I'll open it up for other people to talk since I'm dominating. Others? I guess I'd ask one more question. Are you all treating his anxiety and depression?
I mean, not yet. Of course, we've talked about it, but when we started the discussion before kind of everything fell apart, he was a little bit not on board maybe with all of it. But I think now, and again, we've just had like 1-2 discussions, but he does seem to be more on board that there is that background. So I do think, especially now that he's kind of back with his wife and things seem to be better there, then he'll be more open, but we'll have to see.
Yeah, that is, of course, right. Underlying pain is depression. And depression is pain. So I think sometimes we found that if we talk about it in terms of depression, people get really upset. But if we talk about it in terms of, are you sleeping? We often find that our patients aren't sleeping well, that we can kind of get in on treating pain and even depression through improving sleep. So that's another way to kind of go about it.
Yeah, the interesting piece too is his like lung stuff, his oxygen. He's lost a lot of weight in all of these. But his oxygen stats have been great. He's never had acute chest. He did, I think, wean back on the smoking, especially since he's been in the hospital so much. But so that's kind of been interesting, but maybe that was more of a stress reliever that now he's using. But it's interesting too, he was negative oxycodone. So we feel like maybe some of our patients are selling the oxycodone because fentanyl is a lot cheaper. But so we think that might be what's happening. When we reached out to him, he said that he had an old fentanyl patch is what the story was, but that hasn't been prescribed, at least not that we can see anywhere on his substance abuse.
Yeah, we've unfortunately heard all of those stories and more. The other thing as I would do in the immediate future is get rid of the oxycodone. And I would just have a talk that clearly it's not working, right? You're in the hospital all the time. What we're doing isn't working. So we have to make changes because what we're doing is making you worse. And again, quoting my favorite Pat Carroll, you don't have to be part of somebody's demise. So you want to help him. I'm not saying cut off opiates, but I would get rid of oxycodone. It is absolutely the most dangerous in this circumstance. And it is just one more thing you can do to help make stepping towards getting him to a safe place, I think. Say your question out loud, Dr. Yogi.
Yeah, I can see. So actually, he doesn't have, the interesting piece is he doesn't have a lot of just ED visits. So he goes into the ED and kind of demands to be admitted. And again, that's why we worked with his care plan last time. And he doesn't, I couldn't see any documentation of that, but we have heard we don't use a lot of nasal fentanyl, but sometimes our EMSs do give fentanyl. And I hadn't seen any of that, at least in the past year when he's been showing positive for fentanyl. But again, it's just been probably since late 2021 was when his first fentanyl was positive.
Yeah, no, I think those are always good questions. We also always send any positive UDS. It's not what it should be for confirmation. Of interest, my favorite false positive is there's an edible THC called a Delta 8, which I'd never heard of, but in our system, it's always false positive for heroin. I don't know what it is that cross reacts. It's not heroin. It's just something in that particular substance. So just something else to think about. I'm happy to send you what we do, by the way, for our Suboxone inductions and everything, but you won't be able to, he's not somebody you could just go from now.
Right. Yeah.
But I always start the conversation.
Yeah. And I didn't know too, I think now that yes, because we do send a lot of confirmations too, but like you said, I don't know if anybody has like a very specific, I mean, obviously you can Google things, but like if anybody has a very specific, like this is how long oxycodone's been in, this is how long it would be in your system. This is, just kind of those general, I don't know if there's like a nice little neat way that says like, if you've taken this much fentanyl, it'll still show like, how long oxycodone's in the urine, how long, those kind of things.
I can tell you this on fentanyl, it lasts a long time, about 3 weeks in the urine. But if you send it for quantitative confirmation, you can actually see the levels decrease as someone
Yeah.
stops.
And we've done that. Like he actually has decreased in the since his last admission. So
That's great.
That's
I have a patient that I have to put through rehab because he was totally hooked on oxycodone. And I have been checking every time he comes to clinic. I check the urine for toxicology. He's not using the oxycodone now, but when he was using it, I could not document oxycodone. I don't think he was selling it. I think maybe the half-life in the urine is not very long. Because, you know, he was using it, he was telling me, and I was never able to document that. But you don't know, Julia, because you mentioned about the fentanyl.
I've looked it up. I don't remember off the top of my head. It doesn't last nearly as long as fentanyl. I can tell you that much. But I can't remember off the top of my head. I just happen to know fentanyl.
Catherine, will he be accepting to go to a rehab, or you think that that's out of it's not possible?
Yeah, so we currently have about 2 or 3 males that we've tried to do the rehab, and they kind of just disappear. I don't know, but like we do have a female who goes to rehab and goes to a Suboxone clinic. We put her on transfusions for a little while. We've weaned her off. She's done great for about 2 years now. And the only reason why we still have her on transfusions is because she's not really great at taking her modification meds, and we've really had to get her anxiety and depression under control. But with him not wanting to do transfusions, and we just have a lot of trouble. We don't have anybody in the outpatient world that'll help us with these patients, I guess, is the hardest piece.
Yeah, I'll be honest with you. We have not had a lot of success with a lot of our addiction colleagues. I don't think they understand how to treat addiction in the face of pain. Very easily. And so we've ended up doing it all ourselves. But I mean, again, I think, you know, you did the right thing, started him on hydroxyurea. I would talk about transfusions again, perhaps explaining it to him might make him feel better about why he feels this way. And the other thing is, if he has a baseline hemoglobin of 9 and you're not doing a phlebotomy first, maybe he's getting hyperviscous and not feeling good. So there may be ways you could help him adjust. But, you know, explaining quantity of sickle and all of that stuff, I think sometimes is helpful. But yeah, we've kind of put a protocol together that you have to, you know, get the sickle cell disease under control, treat the anxiety and depression that's underlying, and then you can really deal with what we've essentially caused, right? We've caused this opiate dependency in some respects. And we have not done a good job of treating people, of teaching our young kids, especially on how to manage pain. I think it's something we really have to rethink. And by the way, I especially hate oxycodone. I think it's the devil. So pediatric colleagues, beware.
I was gonna say, for the urine drug screen test, if you have questions and concerns about the UDS and the patients are saying something different, sometimes we'll add a blood toxicology as well to for confirmatory diagnosis or within the urine. And then our toxicology individuals will actually tell you the half-lives of the medications if you ask them, so they can kind of help you through that process as well.
That's also a great idea for someone to come give one of our echo didactics. So we can certainly look into that too and see if we can get a toxicologist to come talk to us.
Yeah, I was hoping somebody had a nice pretty chart, you know, that you could just refer to easily, but you know.
And I think I might have one. If I do, I'll send it to you.
Okay, great, thanks.
Oh, but that was a hard case for sure. Any other questions or any other follow-up from anybody else before we move on? All right, well, thank you very much, Katie. That's a tough case, and hopefully you keep him in care and get him to where he needs to go before something bad happens.
Thank you.
All right, moving right along to not toxicology. I'm really excited to introduce my friend and colleague, Dr. Ofelia Alvarez, who's a professor of clinical pediatrics at the University of Miami, director of the Pediatric Sickle Cell Disease Program, In addition to being a site PI for our Embrace, she is also a PI for the sickle cell disease newborn screening and follow-up program that's also funded by HRSA, and has done research in many, many areas and published many, many papers for a very long time, and have a clear specialty within sickle cell disease. And she is going to talk to us about updates on sickle cell trait. So Dr. Alvarez, I'm turning it over to you.
Lee? Let's see. Are you able to see it?
Yes, ma'am.
You see one slide or two slides?
We see one slide. You're good.
Okay, good deal. All right, well, thank you for the invite. I was thinking what to present, and I chose this, which obviously is not sickle cell disease, but occasionally we get referred people with sickle cell trait in our practice. I personally get referred some babies with sickle cell trait, and then we have to educate the families about what could happen or not happen. And of course, most people do well, but this is just a review about what is published in the literature. So first, the amount of people with trait in the world, which is a lot of people, 300 million is an estimate. Of course, we don't know for sure because there are no registries, and the sub-Saharan continent have about 100 million people. And in the US, it's estimated that between 8 to 10% of African Americans carry the trait, which is about 3 million people. And also 0.2% Caucasians and 1% Hispanics, depending on the nationality, there will be the incidence. And here you have the maps of the hemoglobin S allele and the malaria. Of course, we know the story about malaria that I'm going to tell you now. So just to refresh memories here, you have the cycle where the different mosquitoes, but the worst one is the Plasmodium falciparum, will bite, and then we introduce a parasite. We go to the liver, and then we have a cycle through the blood, and different stages of the parasite. And as you can see, from very early in the middle of the 20th century, there were papers correlating malaria and sickle cell trait having lesser complications with malaria. So the first publication was in 1946. And some data showing that actually the Plasmodium actually inducing sickling in vitro. And also observations that the parasite did not grow well in red cells that contained hemoglobin S. Of course, we know with disease, then the condition can worsen because there's more sickling, more hemolysis, worsening anemia. But with a trait with less amount of hemoglobin S is advantageous. And these are some of the data which is presented in this in 2013 in the Malaria Journal. It is also well known that for the worst complication of cerebral malaria, sickle cell trait is protective. And there was this study looking out at the mouse model of cerebral malaria and looking to see what mechanisms gave protection. So in the mice in this model with the hemoglobin S trait, there were increased levels of free heme. And free heme actually was toxic, and it has this oxidative damage. And the effects are suppressed by the upregulation of heme oxygenase, which actually will change the heme into CO, which is carbon monoxide, biliverdin, and the iron. And what I gather from this is that there was decrease in the damage of the brain itself. they say could be because of elevation of the carbon monoxide, interfering with the T cell response and the oxidative damage of the tissue. So that was in 2011. In 2021, there was this interesting paper in Trends in Immunology trying to explain why there would be a protection of the sickle cell trait with malaria. And again, the story is that the falciparum actually causes oxidative stress in the red cells and increases the surface expression of high mannose glycans, which are used, you see here in the cartoon, the red cells having the high mannose glycan, it will bind to receptors in the macrophages in the spleen. And so it will increase the phagocytosis of the red cells, destroying the malaria parasite. And this expression is higher in the sickle cell trait red cells than in the normal red cells. There's also other processes with less adhesion of red cells to vasculature. So it's more chance for the red blood cells to flow freely in the vasculature and be destroyed in the spleen. And also there is more sickling. So there is basically destruction of the parasite because of the red cell destruction. And so one of the other papers from very early did mention about the protection against severe malaria and hemolysis. Now, going to the clinical part and what are the risk factors for individuals with sickle cell trait, one of the things that we talk about is genetic counseling. I think this is one of the most important things because, of course, most of the time, sickle cell trait by itself doesn't cause any complication. As you know, the lifespan is pretty normal. But there have been some studies in different nations looking at the effect of genetic counseling in terms of reproduction decisions. And it really hasn't made a lot of change. I mean, obviously we have to counsel, but unless in some countries, for instance, the experience in Cyprus and Sardinia, and this was more with severe thalassemia, where there was premarital counseling of the carriers and actually did cause a reduction of the thalassemia birth. But in other nations, including Saudi Arabia, the United States, with the randomized control study, was looking at education of young adults who carry the gene. It improved the education, but did not make a difference in the outcome of the pregnancies. The same thing happened in Jamaica with Dr. Surgeon. I remember actually hearing his talk where he says he had a program with high school seniors and juniors, and there were very much emphasis on educating them and trying to, choose the partners that did not have trade or basically avoiding pregnancies and things like that. And it really did not make a difference. I mean, when you're in love, and it doesn't make too much difference for what you do. Now, things that have been associated with sickle cell trait are, for instance, thrombosis, stroke, chronic kidney disease, kidney cancer, and traumatic hyphema, which is bleeding inside the eye. And one of the colleagues that I have here, Dr. Sacrison, he actually was interested in looking at trauma and the risk for people with sickle cell trait to see whether they have a worse outcome. She never was able to do the work, but I actually saw this publication. Now she's in Chicago, and she's still thinking maybe they do worse, but that is unclear. I mean, that information we don't know. But in this paper from 1997, for sure, the trauma to the eye, it can result in worse outcome for individuals with sickle cell trait. So 64%, the trauma to the eye resulted in intraocular bleeding in people with trait compared to 0% without the trait. So that is important that we counsel people, that if they ever had trauma to the eye and have trait, that they need to have immediate attention. This is an interesting table looking at the population in the UK. And this was published a year ago. So this is looking at, you see here, comparison of over 7,000 individuals that do not have the trait compared to 700 of those who have the trait, and looking at odds ratio of complications. So I put the arrows here, the ones that have the higher odds ratio. So splitting infarction was significantly increased. Now look at the numbers. I mean, these are very low percentages anyway, right? But they're statistically significant in all ratio, although not in p-value. And hypostenuria, so the ability to concentrate the urine, was higher in the carriers compared to the non-carriers. Rhabdomyolysis, of course, we have heard about that. There is a 5.1 OR, so it's significant. And end-stage renal disease also is an OR of 4.9% versus 2%. Again, this is less than 1% in that population. And then renal medullary carcinoma, which is the very rare cancer that can affect people with trait and with disease, actually. This is a review and a Prisma diagram that was published recently in 2018, reviewing, you see there, 7,000 records and having the review of 41 articles about the topic. And they talk about the different complications that can happen. So these in particular were two studies about exertion-related injury and death. And they were published in two different eras, in 1987 and in 2016. And in 1987, there was no preparation for the athletes. So everybody was doing, or in the military, which is the case, the exercise was very strenuous. And this is a very large sample size. You see here, close to 500,000 African-American recruits in the military. So they found 15-fold increase in death among the recruits with trait compared to those without trait. But if you see, the number of deaths certainly was very low. I mean, in percentage, obviously there was an increase, in statistically increase, but the probability was very low anyway. And now in 2016, now there were universal precautions for the recruits. And there were things that were done to reduce dehydration, to reduce exercise-induced illness, heat stroke. And in that scenario with this control things, there was no increase in death. But there was some people that developed rhabdomyolysis, 1.2% of soldiers compared to 0.8% of those who were not having the trait. Now, the vascular outcomes are, I summarize in this table with the references, and I put in bold those who were significantly different. So the venous thromboembolism, again, a large cohort of African Americans looking for those with trait and those without trait. There was a 1.6x fold with 9% of the people that have in the cohort have the trait compared to about 6%. And the same thing goes for the pulmonary embolism. So it was a little bit higher in people with trait than none. And the stroke in this article, although I have seen another one that did not show that, but in this particular article from 2014, there was a slight increase in incidence in stroke in individual with sickle cell trait compared to non-sickle cell trait. Regarding spleen infarction, this is one of the complications that we know it happens, and we usually think it's associated with high altitude when there is hypoxia. When this is when the people can develop acute abdominal pain and have infarction, or if they are flying in an unpressurized aircraft. So this was another paper, very recent, that analyzed 54 articles and it comprised 85 people with the ranges of 7 to 65 years. Most of them were males. And there were various ethnicities here. And one of the conclusions from the article actually was that this association with the altitude was not too clear. Only 39% of the cases occurred when the altitude was above 3,000. Actually below 3,000. So here you have on the table the different variables, and you can see that the altitude, how many people were have the acute infarct, and in the percentage was. So basically over 2,000 meters was the more of the cases seen. And also there was a correlation between the chance of having the infarction and the percent of the S. The higher the percent of the S, the more chance that there were an issue or a risk. Now, the kidney is one of the organs, as you know, has problems because of the acidosis, the hyperosmolality, and chances for sickling in these organs. So there are several complications that can happen to individuals with trait, obviously also with disease, but with trait, we can see that. And one of them is the hypostenuria, so impaired urinary concentration, which is attenuated by the coinheritance of alpha thalassemia. And also hematuria and papillary necrosis can occur, as well as hyperfiltration. Now, there have been several papers looking at the high risk of chronic kidney disease in individuals with sickle cell trait. Of course, these are all adults, most of them adults. And one of the studies, Reason for Geographic and Racial Difference in Stroke, did show that there was a higher risk for CKD in individuals with trait. But there was another study that actually did not see that very clearly, at least not to be a factor on progression. So the conclusion here was that sickle cell trait is a factor for the development of CKD, but not necessarily will worsen or will make it progress faster, but it's one of the contributors for CKD. And also, it could be a risk factor for acute kidney injury. 2 studies show that. Now, renal medullary carcinoma, which is a type of kidney carcinoma, I actually reviewed the literature and published in 2015. And what I did, I looked at all the English papers published until that time, and there were 217 cases of renal medullary carcinoma. Now, obviously, this is 2015. So after that, there have been more cases. But this is the table showing that most of the individuals were people with trait. So about close to 90%. But there were also people with SC, SS, sickle beta thalassemia, and also there were people that were normal. They did not have anything. Obviously, there was a minority, 3%. And one individual had beta thalassemia trait. The majority were males, and the right kidney is the kidney of preference for renal medullary carcinoma. And the presentation was hematuria alone or in combination with abdominal pain. And most of them were metastatic with a mortality around 95%. There were 4 patients that have non-metastatic disease that were long-term survivors. And so the question was, should we be looking for this? Should we be screening for this? But the reality is that it's so rare that it is not advisable to screen, because the likelihood that you will find a case is very, 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 very low. But of course, we should educate people with trade that if you have blood in the urine, you have to look for medical attention right away, because most of the time it's nothing. Most of the time it's a papillary necrosis, maybe they have a kidney stone, but rarely it could be cancer. So it's important to get ultrasound or CT scan or MRI to actually look into this. There is a new publications, a consensus statement for renal medullary carcinoma. And the definition is that the tumor have to have a loss of the tumor suppressor gene, SMART-B1, and also have sickle hemoglobinopathy, as in the definition of RMC. And in the cases that they don't have sickle hemoglobinopathy, the proposal is to call it renal cell carcinoma unclassified with medullary phenotype, because it's so pathognomonic of the trait. The recommendation is to give systemic chemotherapy, usually with platinum-based chemotherapy. This is platinum or carboplatin in combination with other agents, or to look for clinical trials. And they recommend to actually have both these other subtype, which is without the sickle hemoglobinopathy, included in the clinical trial. Now, what about pregnancy? So are the women with sickle cell trait are more risk of having a bad outcome? And this was published by Wilson. These are looking at different things, and obviously with different articles. So what I found for this table is that fetal demise, asymptomatic bacteriuria, and low birth weights were the ones that were more correlated with trait, but in the moderate association, not so strong as other things that we have mentioned earlier. Now, just to end, these are 2 slides about ASH position on sickle cell trait. One of them was in 2012. And this was related to the athletic participation of individuals with sickle cell trait. So ASH at that time did not support testing or disclosure of the trait status as a prerequisite to participate, but they were recommending implementation of universal interventions, which is what I mentioned earlier about the military. And I think this continues to be the case. And here I have just showing this NCAA Division I policy, which actually I didn't know it existed, but when I saw it, I looked for it, which is very long, have many pages with all the regulations to participate in sports. And for the 2012, they say that what was written there, they were not in favor of they were not supportive of that. Now I look at the one that it was published recently, and actually I did not see anything about trait or disease, by the way. I look and I couldn't see it, but I guess in 2012, it was something about it. So ASH strongly supports increased biomedical and population-based research on sickle cell trait, which is certainly important. And then this is the last position that I found on the ASH website, which is the cause of death. And you may have heard, people die and they say they die from sickle cell trait, which is obviously a bunch of lies, right? So they were saying this is inaccurate to claim that sickle cell crisis as a cause of death in individuals well, this is in general, it says a cause of death, but I think what they mean is they cannot blame sickle cell trait as a cause of death. If somebody gets in a fight, right? They kill the person and they say they die from sickle cell trait because they see sickle cells in the blood. Of course, at time of death, everything sickles. So basically, this is just a statement saying that they are opposed to that that conclusion. We cannot say that they die from trait. So that's it. Anything, any questions, any discussion from anybody?
Thank you. That was great. I will tell everybody that we are doing a sickle cell trait study as part of the National Alliance of Sickle Cell Centers to follow 1,000 individuals with sickle cell trait over 3 years to answer some of these questions. What we hope is a way that is more definitive, but also to explore some of the significant heterogeneity, just like we see in sickle cell disease. We can assume that people with sickle cell trait are not all the same either. And so hopefully we'll have some more answers.
Right. So for instance, APOL1, right? I mean, that's a debate whether APOL1 or hypertension or other concomitant processes can be something for progression of chronic kidney disease, for instance. But we don't have the data. At least we don't have the data with a very large population.
Exactly. And those are some of the things we're hoping to answer, as well as the potential for hypercoagulopathy and some other questions of CKD. So.
Great.
Any other questions, Dr. Alvarez?
Yeah. Hey, this is Tom Harrington, Miami. Thanks to Ofelia, another great job. But when you did mention Tanya Zacherson's study in Chicago, and before she left Miami, she had this but doing sickle cell screening in trauma cases. We have inner city hospital, and I haven't seen a large studies on that. To me, I always thought it was a no-brainer to do studies like this. And we still see occasional cases of patients who come in and have just unexpectedly disastrous complications after a trauma, whether it's car accident, gunshot wound, whatever the trauma of the day is. And I think that is a very reasonable thing to do. It's a relatively cheap thing to screen. And I just haven't seen that done in a large way. Since Tanya left Miami, we haven't looked at that, although I have spoken to some trauma surgeons down here. I think it'd be a valuable test and might even allow intervention to save lives and protect these guys.
Yeah, I don't know what she's doing, and I think I have her cell phone, but
yeah, she's in Chicago now. And when that article,
she published this from Chicago, but maybe Julie, if you're doing something, it would be nice to maybe check the trauma. How can you do that?
I don't know that that would be part of this, but it's something that we can mention to Dr. Nake, who's doing a lot of this work.
Mm-hmm.
Yeah, this is it. It actually wouldn't be much. We actually looked into trying to get a rapid turnaround in sickle cell screenings when patients come in. Obviously, if they are known sickle cell trait, that helps, but that's not always the case in trauma cases. But to do a quick sickle cell screen, obviously, unfortunately, it'd probably be a race-based testing, which not always be accurate or justified. But I would say that it may be helpful. I don't think you could test every single person coming to the trauma center, but at our trauma center, it's if we could do this quickly and get the results within an hour or so, I think it could allow us some timely interventions.
Well, we have obviously, I mean, if we want to do a study, we can do like sickle scan or something like that,
Yeah, no, exactly.
You need to have a point of care or some sort of very quick solution, response.
Yeah, you can do this. The labs that are able to do sickle cell screen 24 hours a day, or at least a large number a day, it would be easy. But I think the benefits could be significant.
Right. Sierra has her hands up.
Thank you for that. It was really interesting learning more about trait. But one of the things I thought was really interesting was your ASH statement, because recently I have found out through working with the peds newborn nursing that, to be in collegiate sports, you must show your status,
Mhm.
whether it's trait, negative,
You
or
have to be tested.
positive.
Yep, for NCAA sports.
Yeah. And so I it's relatively new world to me. None of our patients are in NCAA sports, but I guess, this is a burden on the state. And that's one of the reasons we're talking about is, not everyone, and maybe it's just our state trying to find those records or retest people or that kind of thing. But it seems to be quite the opposite direction than, what ASH has put out, as there's really no major impact. I mean, I listened to, the risk for things is higher, but you used to be able to opt out of this, but now it's a mandatory, even to go into trials, like not, just to even try out. So
Yep.
It's interesting. So thank you for bringing that up.
Or
I had
maybe
no
you
idea.
can say that Ash has a different view.
They know, actually, that's part of why this is when this all started. That's why ASH came out with this position, was because the NCAA was going to be testing, and NCAA decided to do what they wanted to do. They know what ASH thinks.
Mhm. Stephen has hands up.
Yes, yeah, this is Stephen Obaro. Thanks very much for your talk. It was great. I just have a comment to make that I am concerned that several of these events that are relatively rare, we may not be able to come to a conclusive determination as to the association with sickle cell trait, just given the sheer small sample size we have here in the United States. So are there any plans to look internationally, to look at populations or countries where the prevalence of sickle cell trait is much higher, where you can sort of ascertain with more confidence the association with several of these relatively rare events?
Well, you saw the publication from in the UK, right? I mean, those numbers, maybe they have, they have a different system of health in there. They have more data, but we're talking about 8,000 people, right? And they were actually able to see differences. They see associations, and this was published recently. Of course, the percentages were low. Maybe some of the p-values are not significant, but they saw association with those type of numbers. So
Right.
I think if we do with the NAFCC, I mean, we are so many centers in here that we should be able to see associations, no?
Well, we're starting with 1,000 people with the goal of getting more funding. This is, again, Dr. Nake's work. I'm just the funder.
Yeah, of course, we're not collecting trade data right now. We're basically collecting disease data. So
We're barely doing that, right? We have to
Right.
focus on improving our understanding of sickle cell disease. We're over time, but I want to give Dr. Pakmabian a
Yes.
chance to ask her a question, and then I want to let everybody go.
Yeah, this is a very quick question. Great presentation, but one of the things that people are often asking, and I'm kind of, how do you deal with this, but very argumentative in terms of sickle cell trait and a vaso-occlusive pain crisis.
Mm,
In your review of the literature, did you find anything
no,
to address that question? Because
no, I actually thought to put a slide on pain, but I did not find anything. So I think, everybody may be different, and maybe that some people may have other associations that we don't know. I know of a hemoglobin called hemoglobin S antilis. I never have actually found a person with that, which are probably is underdiagnosed, but I know that even the trait, they could have pain, because I have read that before. But no, but occasionally, you can have other causes for pain, right? But I have heard that maybe the rainy days, they feel more achy.
I think I agree with you, Dr. Alvarez. I think it's really hard. I think there's a lot of reason people have pain, and they want a reason for it. And it's true, and likely unrelated. And that's what we tell people. And I usually try to look for other causes or send them to other individuals for workup if I'm concerned. But I am going to sign us off because we're over time. And I just want to thank Katie and Dr. Alvarez again for great presentations today. Those were both really helpful and really interesting. And thanks everyone for coming. Much appreciated. See you in 2 weeks.
Bye.